Ladies and gentlemen, can I welcome you all to today's meeting of the Public Petitions Committee, and as always can ask you all, both members and those in the gallery, to switch off any mobile phones or electronic equipment because it does interfere with our sound systems. Apologies have been received from Angus MacDonald, and Jim Eadie is in attendance, a substitute. Good morning, Mr Eadie. I'm glad you could join us this morning. So agenda item 1 is consideration of new petitions. The first item of business is a consideration of 2 new petitions, and as previously agreed, the committee will take evidence from the petitioners in each case. The first petition is PE 1505 by Jackie Watt on awareness of Strep B in pregnancy and infants. Members have a note by the clerk and the SPICE briefing and the petition. Could I welcome the petitioner, Jackie Watt, and also Jane Plum, who's the Chief Executive of Group B Strep Support, to the meeting. Can I invite Ms Watt to make a short presentation of around 5 minutes to set the context of the petition, after which we'll move to questions. Jackie Watt.
This petition is personal to me as I lost my granddaughter at 20 days from the late onset of Strep B infection. At the time she passed, my daughter was told that if there was 1,000 pregnant women in Glasgow, about 800 would be carrying it at the time of birth. And it was just your luck if your baby contracted it. None of us knew what Strep B was, so after researching myself and getting information from different sources, I found out it's a bacteria that is present in the vagina of about 1 in 4 women, not 8 out of 10 women, as Nicole was told. And some babies get it and others don't. But if women were tested between 35 and 37 weeks of pregnancy with a reliable test, then the result is good at predicting whether the mum is carrying Strep B when she gives birth. If she is, she can be given antibiotics in labour, and that reduces the risk of the baby getting Group B Strep infection dramatically. I think information about Group B Strep should be given to all pregnant women as routine part of their antenatal care. I understand that the standard swab test used by the National Health Service will miss out 2 of every 5 carriers. I think every pregnant woman should have the opportunity to have the reliable test for Strep B carriage. The Strep B proper test should be available from the National Health in Scotland. Until it is, pregnant women should be given advice on how to get it done privately. Currently in Scotland, there is no information given to expectant mums, and also no Scottish support group to provide people with the relevant information. That's me finished.
Thank you very much for making your statement to us. Can I also say to Jane Plum, please feel to ask any questions that you want or add any comments, just if you just catch my eye. I've got a couple of questions, then I'll move over to ask my colleagues. Reading the background to this, to your very interesting petition, I note that the UK Screening Committee has ruled against the introduction of routine screening for GBS. What's your own views on that?
We were very disappointed in that decision back in 2012. Because the evidence quite clearly shows that if you screen women, as Jackie said, late in pregnancy, and then offer antibiotics in labour to women carrying Group B Strep, it is hugely effective at reducing the incidence of Group B Strep infections in babies. As we can see from what other countries have done. Research has shown quite clearly that countries that have done that and have done a snapshot of before and after introducing screening, the incidence has absolutely plummeted, ranging from about 71% in France through to about 86% reduction in Spain and the US. So we were hugely disappointed, as were a lot of other people. The National Screening Committee got over 200 comments on as part of their consultation process. Significantly over 90% of those were in favour of screening. So it's not just Group B Strep Support's disappointed. There are a lot of people that are disappointed. And from a Scottish perspective, of course, you're not bound by what the UK National Screening Committee decides for the UK. And looking at the data that's been published so far, it does appear that the rate of infection in Scotland is higher than it is elsewhere in the rest of the UK. And on top of that, the incidence has increased since there was a study done in 2000. The incidence has more than doubled in Scotland. So I think that there's a real argument for examining the data from a Scottish perspective and making a decision based on the population here.
I think that's a very good answer. You've actually predicted my next question. I was actually going to say that very point, that the Scottish Government, of course, isn't bound by UK Screening Committee. Although I would say, in fairness, successive governments have taken on board UK Screening Committee's expertise, and they obviously have Scottish representation. I think, on memory, they have at least 3 members from Scotland who form part of the UK Screening Committee. But they say that there's insufficient evidence of benefits. Do you think then that that's a call for having further, more in-depth studies rather than the fact that screening itself is not going to work?
I think that, unfortunately, the National Screening Committee has looked at data from other countries and feels it's not the best possible evidence. The National Screening Committee, as I'm sure you know, likes randomised controlled trials. But I think it's quite clear that the opportunity to do randomised controlled trials now, that opportunity has effectively been lost because there is so much evidence that screening works. And I think whilst more evidence would be great, we can wait forever for perfect evidence, and we're not going to get there. There is already evidence from other countries that it does work, and quite probably the way forward in terms of better evidence is introducing maybe a pilot study and saying let's do this and see the effect that has.
Thank you for that. Can I bring in Jim Meady and then Jackson Carlow?
Thank you, and thank you to the witnesses, particularly Ms Watt, for her personal testimony this morning. Can I just ask, what are the number of countries that currently have adopted screening? You mentioned some of them: Spain, France, the United States. How many across the world adopt screening?
19 of developed countries, okay. Clearly.
And clearly there is no price that can be put on the health of women and babies. But do you have have you done any work to suggest what the cost of introducing this in Scotland or the UK would be?
No, I haven't. I haven't looked at how much it would cost to introduce. There have been cost-benefit analyses done for the UK, and all of them have come out and said that the cost, that it would be more cost-effective to screen than to use the risk-based approach. And I gave some packs. I don't. Yes, yeah, you got. Okay, and I 2 of the research papers that are in that pack by Camber and Colburn are actually those cost-benefit analyses.
In terms of costing the proposal, is that something you would consider undertaking to do some work on or to commission some work on?
I think it would be very useful to look at the situation in Scotland, because both of those studies looked at the estimated UK incidence rather than the higher incidence that seems to be here. Yeah.
For bringing Jackson Carlow and then Chick Fury. I mean, would it be competent for an individual Scottish university to pick up this research work, particularly if it got research funding, to explore this in a bit more detail in a Scottish context?
I don't know enough about the Scottish universities' research programmes to be able to be competent to answer that question.
Thank you. Jackson Carlow.
Morning. Can I come back to the convener's earlier point about the National Screening Committee? And I note from the briefing we've received, the various countries around the world and the improvement there has been as a result of the screening there. What the National Screening Committee's thing said is there is insufficient evidence to demonstrate that the benefits to be gained from screening all pregnant women and treating those carrying the organism with intravenous antibiotics during labour would outweigh the harms. Now, I haven't been briefed as to what the harms might be, and I wonder if, in exploring or responding to the National Screening Committee's position, you have been able to establish what the anticipated harms might be, or whether that is something of a mystery or what you understand arising from that.
I think yes, I mean, certainly it's something that the National Screening Committee set out in their huge report on it. And there are very real concerns about antibiotic resistance developing, about there being major allergic reactions to the antibiotics in labour amongst pregnant women. And there are concerns that giving antibiotics in that during labour may have long-term impact on babies themselves. Having said all of that, those seem to be the key concerns, plus the concern about medicalising labour. I mean, in terms of medicalising labour, I kind of think a healthy baby outweighs whether or not you're medicalising labour. That's a personal view. The antibiotic resistance issue, actually the drug of choice is penicillin. So it's a drug that is not resistant to group B strep or pretty much anything else. It's got a very good track record. And the concerns about anaphylaxis and major allergic reactions, I know that there is some research that's going on at the moment trying to establish that specifically for group B strep. And there have been cases where mums have had major allergic reactions as a result of antibiotics being given for caesarean sections. But those are different antibiotics, and you can't necessarily say, well, because that's happening here, it's going to happen there. So the evidence from other countries, the evidence from other countries is that the benefit outweighs the risk.
That's helpful. So, I mean, presumably the incidence or prevalence of the potential harms you've just identified will have manifested themselves in the 19 countries who are undertaking the screening and proactive intervention ahead of birth. Do you know what the kind of instance or prevalence has proved to be?
There is very little data published on that, which kind of makes one assume that actually it must be very, very small, because there just aren't the research papers published. So
is it your summation then that the expectation that there could be potential harms is an unquantified assertion, not necessarily drawn from the experience of the countries where screening is now being offered, as opposed to a concern arising born out of the facts of the availability of treatment in those countries?
Yes, I think there has been conflation of risks appearing as a result of antibiotics given for other reasons, antibiotics given long-term during pregnancy, where there are greater concerns about antibiotic resistance. And rather than focusing on the short, sharp doses of antibiotics, typically penicillin, given in labour for a specific purpose of preventing group B strep infections. So I think there's been a sort of, this is what has happened in other areas with other antibiotics given in different ways and different durations. And I haven't seen any research that shows that these are also true for the specific intervention we're talking about.
Thank you.
Check, Brodie.
Thank you. Good morning. I wonder if I may just ask a question about the risk assessment involved. What I don't understand, looking at the information that's been provided, is how, in the current situation where there is no total screening, how one determines those that should be screened and those that shouldn't be screened. How is that determined?
The National Screening Committee, the UK National Screening Committee, is obviously the body that sets whether there's screening or not. And in the absence of any screening programme, then it is a question of individual clinicians making an assessment for a specific pregnant woman and deciding whether or not, in that clinician's professional judgment, they would wish to test.
Stop you on that.
Sure.
In terms of professional judgment, what routine do they go through, do the clinicians go through to say, yes, you will be screened and you won't be? Can you help me on that?
There are no guidelines written in that I'm aware of in the Royal College of Obstetricians and Gynecologists Group B strep guideline that recommends a situation in which a woman should be tested, as opposed to screened. It says in there that all pregnant women shouldn't be routinely screened for Group B strep, but it doesn't define any situations when a woman should be tested. Quite possibly because in 2003, when that guideline was first written, and then in 2012 when it was updated, the standard test that would be used if you were going to try and identify Group B strep is recognised as not being good for the, for that specific purpose.
Can I, just a couple of very short questions. In the presentation which you provided with us, it says the current strategy of risk factor-based screening is not cost-effective compared with screening based on culture. Can you expand on what that means?
The current recommendations in the Royal College of Obstetricians and Gynecologists is that clinicians should use a risk-based strategy. So if certain situations arise during pregnancy, during labour and delivery, then that should prompt the health professional to offer the mum antibiotics in labour. So that's the risk-based strategy. The culture strategy is where you would test women late in pregnancy using a Group B strep specific test, and then based on the result of that, the ECM test, perfect. And based on the result of that, you would offer mum antibiotics in labour. And there's plenty of research that shows, including UK research, that many babies who develop Group B strep infection actually don't have any recognised risk factors when they're born. So the risk-based strategy is never going to identify those. It's only ever, the antibiotics are only ever going to be good at minimising the risk to the babies where there is one or more of the risk factors.
Last question. In the papers that we were provided with, and talk about the enrichment broth, the ECM test, it said the ECM test is currently not widely available at NHS hospitals, but may be purchased privately by post for a fee of approximately £35. Is that that's the cost of the test?
The private laboratories that offer a postal service for the ECM test, that's what they charge for the whole thing. Mum phones up or emails and asks for a Group B strep test. The only test that they do, or the organisations that are listed on the charity's website, we're very careful. We make sure that they only do the right test. So that the mum phones up, gets the test sent, she sends back her payment with her swabs, and the payment is around £35. Absolutely correct.
John Wilson.
Convener, thank you. Good morning. As follow-up to that question, the last question from Chick Brodie, is the issue about privately screening and paying for it. The issue for me is, given if an expectant mother does go through that process, pays the £35, gets the result, and then presents that to her midwife or GP, how responsive are the NHS to those results? Because there's an issue here. If the guidelines say there shouldn't be universal screening, yet individuals can go and get an individual screening and pay £35 and then present that to the hospital where they're being treated, does that hospital then take on board the results of that screening test? Or do they apply the standard recommendations that are coming out at the present moment to say, well, that's fine, you've had that test carried out, but as practice, our practice in this hospital is that we don't do any follow-up work on that issue?
Clearly, different hospitals may well have different policies. The recommendations, both from the Royal College of Obstetricians and Gynecologists and from the National Institute of Clinical Excellence, sorry, that's not their latest title, I've forgotten it, but nice. Both of them say that where Group B strep has been detected during the current pregnancy, then mum should be offered antibiotics in labour.
That's where it's been detected, but in relation to the private route we were talking about in terms of paying the £35, do they accept that private testing as a standard that allows them to then go and carry out further treatment in terms of antibiotics?
What we're hearing at the charity is the vast majority do, because the existing guidelines don't say where Group B strep has been found from an NHS test. It is just where Group B strep has been detected in the current pregnancy from a vaginal swab or a urine sample or wherever.
It tends to, to my mind, tends to fly in the face of what you're requesting in terms of your petition, because if the recommendations, national recommendations are there shouldn't be a standard across the board test for pregnant mothers, then clearly if they then accept anybody that comes back with the test results of the privately ECM test, then that clearly shows that there is a need for that. The other question I have is that we have what is defined within the paperwork as high risk, low risk pregnant mothers. How do we define high risk and low risk in these circumstances? Is there a definition of high risk and low risk?
There are the risk factors are usually defined. If one or more of the risk factors is present, that's usually defined as as high. I prefer to say higher risk than high risk, but that's usually it. And low risk is where none of those risk factors is present. And actually, I totally agree. What you've highlighted also is an illogicality within the current Royal College of Obstetricians and Gynecologists guidelines, because they're saying don't routinely screen all pregnant women, but they're also saying if it's found, act on it.
Well, if it's not a case of it's not a case of it's found. If someone then comes along with evidence to say that it's there, then it's treated, and it's the private route. Whereas what I'm trying to look at and here is that if we don't have routine testing, then it means that only those who are, one, aware that the test can be done privately, and two, can afford to pay for the test, are likely to receive the necessary treatment from the NHS to actually combat any risk at all.
There will be some pregnant women that Group B strep will be detected for if these sort of general non-specific swab tests are done. Although they're not very reliable in terms that they will miss a lot of carriers, they will find about half of them. So when, clearly the issue with that is not the half of the women that they find are carrying Group B strep. It's the half of the women who are carrying Group B strep and told, no, there's nothing to worry about. But I totally take your point, it is inequitable.
The other issue then arises is the testing that's being carried out by NHS. Is it sufficient? Because if you're saying the ECM test that's been carried out privately by the organisations recommended on your website are accurate or potentially more accurate than the tests conducted by the NHS, would it not be proportionate to say that the test there should be a standardised testing method to ensure that no one, and you indicated something like 50%, up to 50% of those tested in the NHS are told that there is no problem. In reality, there is potentially a problem there.
Yes, and that there does exist the what used to be the Health Protection Agency and is now Public Health England has a UK, it's an SMI, Standard for Microbiological Investigations, and there's one, the SMI B58 is in your packs, which describes the right method, that if you're going to be looking for Group B strep, this is, and it is the ECM method. And I still find it surprising that those guidelines were put together in 2006, and I still find it surprising that only a handful of NHS trusts make that test available to their health professionals to request.
Thank you very much indeed.
Thank you. Can I just, unfortunately we are a bit short of time, but just ask you some advice on perhaps next steps, because it's quite a technical area. Do you feel there is any further mileage that this committee can helpfully deal with as far as the UK Screening Committee is concerned? I mean, for example, would it be worth us meeting with the Screening Committee to raise these points directly with them?
I think that I think conversations are always useful. I think that the next time that the National Screening Committee will be reviewing their recommendations for the UK as a whole will be 2015-16, and maybe that's the time to have that direct conversation.
And would it also be then useful for us to perhaps write to the Scottish Government to ensure the information is given out routinely to expectant mothers, if that's not already been given out? What's your perception in Scotland? And maybe Jackie Watt's more familiar with that. Do you feel there is enough information given to expectant mothers in Scotland?
It's very hard to find information.
Right.
And when we went to speak with the paediatric doctors and consultants that had cared for my granddaughter, he didn't have any information or any handouts or anything that he could give us. And just lately, he printed something off Jane's website and sent it to us, so I feel as if there's nothing out there, there's no surgeries at the maternity units, there's nothing making you aware of Strep B, no leaflets, no signs, symptoms, so...
So then it does seem there is a gap here that perhaps we could usefully, if the committee agree, write to Scottish Government to try and raise awareness so that expectant mothers are given more information. Would that be a useful course of action?
I think writing to the Scottish Government would be great. We've written recently and we've had a couple of responses which I printed off copies, if I may share them with you, so that maybe the questions...
If you could perhaps leave them, that would be very helpful.
Yep.
Right,
but in terms of asking the Scottish Government about information, there is a little bit of information in a booklet that's given to all pregnant women. But actually there needs to be some sort of proactive information given. And if you're giving information, what are you doing? Are you saying, are you going to say, if you want to be tested for this, the only route is private? Or are you going to be saying that actually if you are to be tested for this, then within Scotland we are going to be making sure that you are offered the right test, the proper test for the job. And I think there would also be mileage in perhaps asking the Scottish Government to review the situation on screening specifically for the Scottish population.
Well, the next step is that the committee then goes into summation mode, where basically we stop questions and we decide on the next steps. But I think you both have given us some very helpful signposts to what the next step should be, because obviously this is a technical piece of work, but obviously one that has terrible outcomes, as Jackie Watt graphically described sort of earlier on. Well, certainly my thought... Sorry, Chip, do you want to come in first? Yeah, I was just going to suggest, certainly take on board what Jane Plum and Jackie Watt suggested. I think certainly we need to write to Scottish Government flagging this area up and seeing whether better information can be given to expectant mothers. I also take the point in Screening Committee that 15-16 is going to be a crucial period. So if we were going to have a conversation with them, either by some form of e-conferencing or face-to-face, presumably the end of this year would be a useful time before they start their programme for next year. Again, my thoughts to the committee may be that either by telephone conference or video conference or in person, we could meet a representative from the Screening Committee perhaps at the end of this year, which fits in nicely for their programme of 15-16. Chuck Brodie? Yeah.
Well, I agree in general with that, but I happen to agree with the last comment that Jane Plum made in terms of having conversations. No bad idea, always helpful, but in terms of the numbers that we were talking about, and I suspect the costs that we might ask in our letter that the Scottish Government seriously consider application of screening to all those that are pregnant.
Sure, and that perhaps would need some more Scottish-specific research. Jackson Carla?
I would like to write to the National Screening Committee to pursue this issue about the potential harms that they identified, and to ask whether in fact they have quantified these in any meaningful sense. And unusually, and I hope this is in order, I would like to write to the American College of Obstetricians and Gynecologists who introduced advice in 1996, or to the Centre for Disease Control in the United States, because they have been applying the policy now for a period that would be long enough for the harms that were identified in evidence to us to have manifested themselves in a quantifiable way. And I think it would be useful for us to have that information, if only to use to some effect potentially at a later stage were we to be meeting with the National Screening Committee to discuss these matters further.
That's a very, very good bits of advice. Can I ask other members their view? John Wilson?
I would agree we should write to the Scottish Government. I'm looking at some of the figures here, and in relation to their UK figures, we don't have a breakdown, I assume, for Scotland's specific figures.
In the package.
And we only received the pack just before the start of the meeting, so we haven't had a chance to read through them.
The incidence in Scotland for 2012 of the early onset cases, which are the ones that are mostly preventable, potentially preventable, is 0.47 cases per 1,000 live births. For England, Wales and Northern Ireland combined for 2012, it's 0.36.
So the incidence in Scotland is higher than the rest of the UK.
And there was and that is voluntarily reported. It's not a notifiable disease, so that's voluntarily reported data. There was an enhanced surveillance study that was done back in 2000-2001, and at that point the rate per 1,000 live births was 0.21 in Scotland. So it's more than doubled, or the data has more than doubled in that period.
Convener, as I was saying, I think it would be worthwhile writing to the Scottish Government to try and get, the figures that Ms Plum has provided are useful, but given it's a non-reportable situation, it might be useful to ask the Scottish Government whether or not it would consider making it a reportable incident so that we can actually get accurate figures. The other issue, Convener, I would like to raise is to ask the Scottish Government whether or not they would consider where a expectant mother requests the test be carried out, as to what their position would be on that issue, because while I accept expectant mothers can pay the £35 and get the test done privately, not every expectant mother is in that situation and is not aware of the availability of that test. So it would be useful to find out if the Scottish Government would consider a policy change to ensure that every woman who requested that test be carried out have the opportunity to have that test carried out.
Thank you for that. David Torrance?
I'm happy to write to the Scottish Government and at the National Screening Committee, give evidence at the end of the year, because I think that's vitally important.
Thank you for that. Jim Eadie?
I fully endorse and support the constructive suggestions that have been made by other members.
Right. Well, thank you very much. Thank the members for that. I think that's some very constructive points that we can take this issue forward. And can I thank both our witnesses today, our petitioner, Jackie Watt and Jane Plum. As you can see, we're going to actively pursue your petition in every single way that we can, and obviously we'll keep you up to date with developments. And if you have further information, perhaps you can leave it with the clerks. And I'll suspend the meeting for 2 minutes to allow our witnesses to change round. Thank you very much.